Hi, my name is Pamela Downey and I'm a physical therapist and a board-certified women's health practitioner. I got interested in this topic because of my beginnings in spinal cord injury rehabilitation, if you can believe it. I've come in differently than some other practitioners that really enjoy the orthopedics and the pelvic side of things, but I came through it through the neuro side where people were having bowel and bladder accidents, and I was like, wow, that is something that keeps them from having full function and a productive day of activities of daily living. When I looked into it, the able-bodied population actually has a lot of problems of their own. The able-bodied population actually can benefit so much from interventions that physical therapists can provide that may be more difficult in someone that has a neurologic injury. In finding that, I went back to school and got my doctorate and spent a lot of time lurking in the literature and finding all about pelvic floor dysfunction and abdominal wall and intra-abdominal pressure. And I really enjoy bringing these topics to clinicians to help demystify working with the pelvic floor and our pregnant patients. This is a 3D model of the pelvis, and it shows the musculature. And I wanted to introduce the pelvic floor muscles. We have 3 layers of the pelvic floor, and the one that you're seeing right here is the superficial layer. So we're looking in the lithotomy position, and that is a fancy way of saying the supine hook-lying position. So we're looking up into the body, and you can see that this is a female model with a vagina and the anus. And the 3 superficial muscles of the pelvic floor are the bulbocavernosus that encircles the vagina, the ischiocavernosus, which comes from the ischial tube up towards the clitoris, and the superficial transverse peronei, which come across the bottom, and they form a triangle, and it's called the urogenital triangle. The other muscle, the external anal sphincter, is also a superficial muscle, and that's located in the anal triangle. So if you divide the pelvis, you have 2 triangles. The posterior aspect is the anal triangle, and the anterior aspect is this urogenital triangle. Now, from our perspective, when we want to exercise the pelvic floor, you can think of the 2 triangles as a diamond shape. So you can connect the bony prominences. So let's just look at the bony prominences. We have the symphysis pubis, the ischial tuberosities, and the coccyx down here. So when you connect the dots to make that diamond shape, that contains the muscles of the pelvic floor. Looking at the second layer of the pelvic floor, she's got a very sturdy pelvic floor, we have the deep muscles called the levator ani and the coccygeus. These are the muscles that get a lot of press, and these are the ones that we can most feel when we do a Kegel or a pelvic floor muscle contraction. The important part is that the pelvic floor is not an all or none muscle. When you contract it, it doesn't have to be 100% on and 100% off. It's a postural muscle made up of about 60% of slow oxidative fibers. So this muscle is on 20 to 30% as we're walking around doing our typical daily routine. So within Pilates, we should mimic the routines that the pelvic floor does. And when we exercise, we do maximal contractions, but we do a lot of low load sustained contractions as well because we want to build endurance. And I think that is the fallacy of doing the typical Kegel contraction, which is just doing a quick on and off of the pelvic floor. So one aspect is that we should exercise it both in the quick phase where you just squeeze on and off, which is handy when you have a cough or some other intra-abdominal pressure coming from above. But really, from the day-to-day, hour-to-hour, we should be exercising the pelvic floor to do its postural job, which is sustaining load over a long period of time, or while you're carrying something or doing other things that the pelvic floor has to be very supportive to the viscera and trunk above. I have a course with Polestar Pilates that works on knowledge base for pregnancy. And I think the take-home points that you will be very comfortable practicing in your clinic or your studio on Monday morning after the course is your comfort level in general, that you know you're not going to hurt or injure your client, and that you'll have important safeguards and exhibit the precautions that you need to work with someone that may be pregnant. For instance, we will learn all about the abdominal wall and the presence of a diastasis recti, how to palpate for one, how to check for muscle strength, and also awareness of the other core muscles such as the pelvic floor, the multifidus, and the use of the diaphragm. Because the core muscles are so important for regulating intra-abdominal pressure. Another aspect that you will learn is how to apply Pilates exercises safely in the pregnant client, how to modify your equipment to exercise these individuals, and how to get them on and off the equipment safely, which safety is the key factor for this population. Getting on and off the equipment in the Pilates environment, if you've ever done it with, say, an elderly person or someone who has a little bit of a range of motion difficulty, it can be awkward on the reformer. It's important when you're bringing your client onto, say, a low allegro or onto a studio style reformer, that you have an idea of body mechanics and be able to teach them prior to them doing on their first attempt how they're going to organize their body in space and activating their core musculature so that they don't put too much pressure on the linea alba, which is the connection of the rectus abdominis, that would cause a tensioning or separating, which we know as the diastasis recti. So the more that we can educate the patient on simple things like getting on and off the equipment can then transfer into their home or work environment where we're not with them but 1 hour, and the other 23 hours a day they can use the safety of their body mechanics skills and the exercises that they've learned here in the studio with improving their posture and their ability to move in their environment safely. Another point of the course that I think is interesting is that we as clinicians and women taking the course can also benefit as we talk about those things that no one ever talks about. Dyspareunia, which is painful intercourse, prolapse of the organs, and these things come from being either hypertonic in your pelvic floor or having supportive issues. Interestingly, cueing in the Pilates realm is always about pulling up and in and a maximal contraction of the pelvic floor. But actually, people in the room vary. You can have some people that have a support issue or happen to be very flexible or have lax ligaments. And then there's the other half of the room that they're actually a little hypertonic or tight or have less flexibility when compared to our standard model. So it's important to recognize in your clientele which person you're dealing with. Do you have a supportive dysfunction or do you have a hypertonic dysfunction? And then you can apply exercise properly for the individuals that you're training.